Ladies and gentlemen, well, welcome to the December board, the last board of SWFT before the Christmas break. Lovely to see you all. If I can make sure that all of you are on mute, because I can see some of you aren't on mute and it affects the acoustics, that's great. Well, I'm delighted that we start all of our board meetings with the celebration of some fantastic things going on with our teams. So it's a Going the Extra Mile Summer Winners Award. And so first of all, we've got the COVID-19 SWAT team. Round of applause for everyone. And so I'll just read out a few words, but during the first wave, the team were awarded the Summer Award for Going the Extra Mile because, frankly, you were unbelievably efficient and unbelievably reassuring. And during that period between April and August, the work you've done has been absolutely extraordinary. And we can't thank you enough. I mean, despite having to work in a gazebo and other sort of odd places, you are absolutely fantastic. And on behalf of not just the board, but the people of Warwickshire, we want to put on record our thanks. So the Going the Extra Mile team winner for the summer is the COVID-19 swabbing team. So round of applause, please, board.
Everybody.
Thank you. So we then move on, and lovely, perfectly timed, Karen, to the non-clinical Going the Extra Mile award winner, and it's Karen Taylor. And Karen's our pre-graduate development lead. And Karen, you've been an unbelievable positive role model for so many people going through the process. You've been supportive and accessible, and you've helped to develop the clinical support workers induction program. And everything you do and the way you do it is such an embodiment of the values of the trust. And many staff were, I know, apprehensive about being redeployed, but the way you helped them was fantastic. So it's my pleasure, again, round of applause on the board, to give you the Going the Extra Mile Non-Clinical Winners Award.
Thank you very much. Thank you.
Now, I know for those of you who win a Going the Extra Mile award, it's normally the excitement of having a photograph taken with Glenn or I, which makes you go the extra mile, but that can't happen in this digital world. So Glenn and I apologise for that. The final winner for the summer Going the Extra Mile Awards is our clinical winner, which is Leslie. And so that's Leslie Williams. So I'm not sure Leslie's with us, but Leslie is a senior staff nurse and had an enormous impact on moving to the 23-hour ward from Willoughby ward during the COVID-19 pandemic. The person who nominated them said they wished there were more Leslies in the world.
Okay.
Well, I wish there were more Alissas, more Karens, and more Sues, as well as more Leslies. So congratulations in absentia, Leslie, for the Going the Extra Mile Award. Oh, Leslie is on the call, so Leslie, I can't see you, but I hope you heard that.
That I did hear, yes.
Okay, great, thank you. Now we've got also what's called the Chairman's Award. And so the Chairman's Award winner is Susan, who's also on the line with us. And Susan, you know, there are lots of different ways our staff embody what the trust is about. But what you did on the 24th of April this year was absolutely extraordinary. For those colleagues who aren't aware, Sue was on her way home and was the first on the scene to a car and cyclist collision. Someone's not on mute, so can I just ask you to go on mute for a sec? And the cyclist was in a really bad way, and Sue, without a second thought, stopped, did a CPR, I think, for 20 minutes, and managed to get a pulse back. And the cyclist went on to the QE and has recovered. But Sue, it was your bravery and courageousness that saved their life that day. And as I understand it, your behaviour was so impressive a member of the public who was watching decided that they wanted a career in the NHS. So not only have you saved a life, you've touched a life, but your example touches many other people on a daily basis. So I'm delighted that you win my Chairman's Award for this year. So thank you very much.
Thank you. Thank you.
No, thank you, sir. And I know that the family are incredibly grateful. So it's extraordinary what you did. So thank you very much. So team, we now move on to the rest of the board business. You're very welcome to stay. The board meeting can be exciting. I'm not sure this one is going to be, but you're very welcome to stay. But otherwise, I will understand if digitally you disappear and do other stuff. But again, thank you all very much.
Thank you.
So, ladies and gentlemen, as I said, welcome to the board. And I don't think we've got any apologies for absence, but I do need to make members of the public aware our Chief Executive, Glenn Burley, needs to leave just before 2:30 for a very important national call. So I will try and push the agenda ahead to get to Glenn's report before he goes. But Glenn will be disappearing for about an hour. So any new declarations of interest, please raise your hand if you have any new declarations of interest. Okay, thank you. Any changes to the minutes of the meeting held on the 4th of November? Bruce?
Yes, thank you, Russell. On page 7, that's 2333, the second paragraph would read better and more accurately that Mr. Paxton commented that he had spoken with the Director of Nursing and the Medical Director about engaging with junior doctors more at CGC and to develop an assurance stream for cancer services.
Thank you very much, Bruce. So can we make that amendment? Any other amendments? Okie dokie, Bruce, if you could take your hand down, that's super. Thank you very much. So we move on to matters arising then, which are on, I think, page 23, I think, of, no, page 17 of admin control. The first was the revised constitution, general amendments. That was done. And the revised governor tenure. The Council of Governors and the Board of Directors couldn't agree on that, and so the current situation of unlimited governor tenure continues. The next action point arising was Bruce to update the board on the audit assurance stream for cancer services as it develops. Bruce, I assume that's ongoing?
It is ongoing, and there's a comment in the clinical governance report today.
Okay, super. Thank you very much, Bruce. We'll come back to that later. And then for next board, which is on the 3rd of February, Glenn to bring the place-based clinical strategy back. So that's in hand, Glenn?
Yes, it is.
Thank you. And then Charles to bring back the medical revalidation report, but that's for next year. So looking forward to that. And then Anne to include some data within her report around recruitment figures by gender profile. That's for next May. Also for next May, and to invite 2 members of the BAME network. So that's in hand. Thank you, Anne. Then the upload the photographs and the showcase of the digital hub. The official launch date, we now have, Glenn. Can you just recall? My understanding is.
I was hoping you weren't going to say that because I can't remember the date.
It's the week after next.
It's the week after next, Chairman.
I knew it was. Thank you, Glenn. So we'll just make sure that that's on the website. So we're really delighted that the Secretary of State for Health has recorded a message and about the new digital hub. So we'll make sure that's on the website, please. And then Helen to ensure presentation on digital innovation come back to a future board. Helen, that's in hand. We did have a really good session this morning on our EPR update. Some really great work which Helen is leading with clinical and IT colleagues on the way our systems need to develop to make them really fit for purpose, to help patients and the way we work internally. So really good work being done on that. Anything else you wanted to add to that, Helen?
Thank you, Chairman. No, I don't think so. I think once we've done the launch of the digital hub, we can start then to bring things back regularly in a regular slot around some of the innovation that we're doing through there. So what I probably want to be doing is having a regular slot in board or in the workshop where we can present that.
Fantastic. There's some really good technologies we're now developing, aren't we, for people with Alzheimer's at home and that type of thing, some very innovative things. And then on the integrated performance dashboard, Helen, to bring back to board or workshop the positive work done with primary care and share that with board colleagues. When are you planning to do that, Helen?
Well, we had a discussion this morning, particularly in our joint restoration board, around 3 of our work streams that we've got moving forward. So one of those is around outpatients. We've got a frailty work stream, and we've also got an urgent care one, and we've done those jointly together. So my intention would probably be February or March time, because actually we'll have made a lot more progress by then, and we've done some really fantastic work all together. So we should have nailed down quite a few of the little things that are left to do, but also looking at what our phase 2 is around a number of those developments.
Thank you, Helen. And then the last one was on the digital hub. Any matters arising that I've missed? Colleagues all happy to move on? So the first thing is an item for approval, which is the Non-Executive Director, Finance and Performance Committee revised term of reference. Sarah, please.
Thank you. So happy to take the report as read and recommend approval for the non-exec F&P terms of reference.
Thank you, Sarah. Any questions on those terms of reference? Sue?
Yes, thanks. I just wondered on page 2 under performance improvement plans, it talks about the committee monitoring benefits from significant investments. And I just wondered if the committee will be advising what parameters those are, so that we know which size of investment are going to be reviewed.
No, I think that's a fair challenge. Glenn, your perspective?
Yeah, I think the protocol we've used in the past on that has been those that have required board approval as business cases. So it's the £1 million threshold, I think, is what we've used before.
Okay, can we just double check that? Can we double check that and just make that amend? Anything else from colleagues? So if you're not happy to approve, could you please raise your hand? Okay, duly approved. Thank you very much, Sarah.
Thank you.
We'll then move on to the Chief Executive's report. Glenn.
Thank you very much, Chairman. If you could just kind of edit the video and I'll answer your question from earlier. It's the 15th of December, Chairman, the launch of the digital hub. It's actually a digital launch. So what we will do on or around the 15th is put the video up there that we will have made as part of the kind of explaining to people what the hub's about, and I'll report on it, no doubt, at the following board meeting. So in my paper, just a few things I just wanted to highlight, if I may. So firstly, I talk about testing. What obviously isn't included in here is today's news about the Pfizer vaccine being approved by MHRA, which is good news. It's a complex logistical exercise to deliver that vaccine, and we're working through that at the moment, but that should be available for some NHS staff very, very soon. I talk about lateral flow testing, which is the regular testing of all frontline NHS staff. Millions of kits have been distributed across the NHS, and we've delivered those for our staff. They can do that at home, and there's a very low level across the NHS of asymptomatic positives coming up, which is good to hear. Also report here, finally, we've got the rapid testing equipment on site. It hopefully will have some more at some point, but at the moment it meets most of the emergency admissions needs of the organisation. It's taken a little bit of time to get in place. Then I'll talk about a presentation I gave to the HSJ provider conference last week, which is discussing the notion of how you create safe sites for delivering NHS care whilst COVID still circulates. My argument is that we need to make all sites safe, and we need to have green pathways rather than separate sites, particularly because one of the main causes of infection is from staff who bring COVID in from contacts in the community or in their own home. So even those elective only sites are at risk of that being an issue. Then the report goes on to explain that on top of the pressures of COVID this winter, one of the things we still need to remember is the things that we always do well actually in this organisation, which is managing flow. And if you looked at the data in early November across the Midlands, then we had a very similar amount of bed occupancy associated with COVID to the amount that we could free up if we just moved to best practice on super stranded and stranded patients. I'm pleased to report that we are in that best practice category, but many trusts aren't. So that would really help capacity, but also more importantly, the outcomes for those individual patients. I then talk about something which board members will be familiar with. We had a presentation at our 3 boards meeting from Dr. Chris Turner, who's the national founder of the Civility campaign. And we think it's a really good campaign, particularly over this winter, to get behind, to demonstrate to our staff that we're going to support them, we're going to support civility in the workplace. And indeed, as an executive team, we've had a conversation about this and agreed some principles that we're going to sign up to and lead on. And then there's a poster there which helps to make the point, which some of us will have seen as part of that presentation. And the comms team have also been developing some material that we can share across the organisation. I then talk about the interesting issue of car parking, which I won't dwell on. And then we've decided we're going to have a feature each month about one of our teams, and the team that we feature this month is the orthopaedic team, who in response to COVID have had to significantly change the way they work and where they work in some cases, with the use of the local Nuffield Hospital. Some great partnership working, some really great recovery stats that we're seeing for our elective services here at SWFT. Just a heartwarming response from, this was written by the general manager responsible for the service, but really good to see the work that they've done. And then finally in the report we go through the winners of the GEM awards that we delivered at the start of this meeting. So I'm happy to take any questions from anyone, if that's okay.
Thank you very much, Glenn, and thank you very much for the work you're doing at national level to help steer the NHS to the next stage of its development. It's very important work. Any questions or perspectives to Glenn? Please raise your hand. Stunned everyone into silence, Glenn. Thank you. So colleagues, happy to move on to the integrated performance dashboard. Anne, do you want to give us an overview, please?
Yeah, thank you, Chair. As we discussed yesterday in non-exec F&P, October has been a reasonably positive month for us across a range of indicators. Managing Director commentary is really drawn from the executive reports, and responsible execs will no doubt provide further detail in their updates. We've talked, and indeed in Glenn's report, it references workforce, and I think there are 3 things I would want to draw out. The steady recovery is really reflective of our workforce and the confidence that they've got, and how they're adapting to working in a COVID-19 environment. The work that our patient experience team are doing to support teams adapt and identify improvements to the response rates of the I Want Great Care measure. And finally, the work our HR team are doing to really target and support our colleagues working in critical care and frontline areas, and to make sure that they receive appropriate support at this time. So those are the key points I wanted to draw out. Happy to take any questions before I hand over to my colleagues to go into the detail.
Thank you, Anne. Any questions to Anne? Bruce.
Hi, Anne. You make a couple of paragraphs make reference to the testing regime. Would you comment on the reliability, indeed suitability of turnaround times, and if they're not good enough, what the pathology network operating partner is doing about it?
If I may, Bruce, if Helen's closer to the to that contract than I am, if I can ask Helen to pick that up.
Fine.
Thank you, and thank you, Bruce. What I can say, I think there has been some challenges for us, particularly with the reliability of the equipment within the pathology network, and it has caused us to have increased delays in the turnaround time, particularly over November and the early parts of this month. I think the board should be assured that we have significant infection prevention and control measures in place, as well as social distancing to try and manage that. But it has had an impact on us from a flow point of view, ensuring that we get patients to the right place at the right time as speedily as possible. We are so I have a daily dashboard from the pathology service around their turnaround times, and we are introducing more rapid tests this week, and we have had an increase in urgent and prioritisation. I think some of the stuff that we are doing within the organisation to try and take some of the pressure off the pathology network, because I think they are under significant challenges with the reliability of their equipment. We're ramping up the amount of services that are going through the home testing service, particularly for our elective pathways, so that patients can swab themselves and send that through, which then alleviates some of the pressure within the pathology service while their equipment and some of the consumables that comes through the supply chain, that's been challenged for them as well. So we're onto them daily, and I know that Glenn had his hand up a minute ago, but obviously we have done quite a lot of escalation through the system and nationally to try and get them some mutual aid as well.
But bottom line is their performance hasn't been acceptable. I know there are reasons for it, but the bottom line is their performance hasn't been acceptable. Glenn, anything you want to add?
Yeah, I mean, up until very recently, we've been very reliant on that off-site swab service. But obviously now we have rapid testing on site. We are less dependent on that. As Helen said, there is home testing capability for our elective pathways. So the test that we will now need to send off site will be more limited. So there'll be the day 3, day 5, and prior to discharge to care setting swabs, which hopefully the network will be able to cope with that kind of reduced level of demand on the main lab in Coventry.
Okay, super, thank you. And any other questions to Anne? Okay, so we'll move on then to Fiona's report, please.
Thank you, Chair. So just bearing in mind timing, I just want to pick up a couple of things, just preempting some questions or observations from the board. One would be a question around friends and family tests and how we are intending to improve that rate post-COVID. So you'll note from my report that we've only just relaunched that, and it is actually only an expectation from the CCG to start and NHSE to start reporting that in December. So we relaunched it last month. It is low numbers at the moment, we know that. One of the specific questions I had from a NED before board was, are we the electronic mechanisms enough? I think in my report I refer to the QR code and that being issued to all patients as an alternative to filling in the paperwork. I have got to say that the Friends and Family Test, I Want Great Care test is a blunt tool. It doesn't really give us very much. And if you go electronic, it gives you even less. It basically is a yes or a no, whether you recommend the care or not, and no ability to give commentary. So I think our alternative really is to engagement strategy across the system at place to ask the appropriate questions of our public around our services, and really spend the time doing that in terms of a better qualitative survey rather than this blunt tool, because it doesn't really give us anything. You know, it sometimes gives a flag, but that's really it. So you know, I'm happy, and I will, and our team is continuing to push it, measure, do. There's better ways of engaging. The triangulation observed is the reference to a wrong site surgery never event as an SI that we've reported this month, and a slight decrease in our WHO checklist performance, and that can be triangulated to say, have we got a problem in theatres? So just to give assurance to the board that Charles and I are intending to do a safety review into theatre, just to question them about their practices, observe their practices, and really clinically engage them in a good conversation about that culture, just to get us more assurance, but also more detail about what is working well and what's not. And we're reviewing the whole process around, in the safety team, around WHO checklist to say, have we made it too complicated? Have we got the right people involved? And relaunching that within the teams. I have got to say 97% isn't bad, but and our 100% target, I've said before to the board, is a difficult one to achieve. But even so, I just want to give assurance that we're not becoming complacent there, and we are responding to those triggers. But apart from that, I'd like to just take questions if there are any. Thank you.
Thank you very much, Fiona. Questions or perspectives to Fiona? Chris.
Hi, Fiona. In your report on the medication errors, you mentioned that there continues to be a high number of incidents related to insulin. Yeah. Can you comment on that for me?
Yes, the insulin errors have gone back up recently in community. So if you remember, about 18 months ago, we did a piece of work with team to review everybody that was insulin dependent in the community and take them off insulin if they didn't need it, or it was or we could medicate them slightly differently. And that was partly about workload of the district nurses, because we knew at that time 40% of their workload was about giving insulin injections, but secondly, to reduce some of the errors that were happening. That work continues. We do have an ongoing issue in the north with people coming out of UHCW on different prescriptions, but it has tended to, well, there's 2 or 3 in month, I think, incidents, 2 in the north, 1 in the south, about discharge and new prescriptions of insulin not being picked up as part of the discharge summary. So I think I said at the last board, definitely clinical governance committee, that we've just set up a project to look at discharge processes and make sure that communication, both from the medical team in terms of the TTO and the ongoing communication and link with the GP, but also the nursing handover to the district nurses, is robust enough. So that's what we're partly doing about it. The other thing we've just done this week is send out a screensaver and a safety alert, just raising awareness of these incidents and reminding them of their responsibilities in doing those checks.
Great. So will you bring that to the clinical governance committee?
Will I bring that
a report back to the clinical governance committee?
Yeah, so medication errors and by drug type is included in the patient safety report, so it'll be brought up in there, Chris.
Okay, right. Thank you. Thanks.
Thanks, Chris. And Rosemary?
Thanks, Fiona. Just a question on falls and falls with harm, where it's obviously slightly disappointing to see sort of an increase in the falls with harm, and in particular of death as a result of that. So just wanted some comfort that, you know, steps are being taken to address that? I know you're putting in more false alarms, and whether we're seeing any changes there.
Yeah, so we have put more falls alarms and more falls beds. As my commentary suggests, the analysis that we've done on the falls and the reasons for that, which again will come back to clinical governance, is around a change in acuity since COVID. It's the patients are sicker, they're more frail. And they are in isolation, and it takes time for us to get into the room because we're donning and doffing our PPE. Several factors are accumulating to be risky. Just again to give you assurance that the corporate nursing team is currently this month just completing that acuity review to really measure it compared to what our acuity has been before, and what that does and looks like in terms of our budget setting and ward establishments going forward, if there is a requirement to do a skill mix review or an investment there. The other is I suppose reassurance. The trend it's within, from a statistical analysis, it is within limits. So it was the July figure that was significantly higher, but actually the harm rate is within those control measures. So we just need to be mindful of that it's not an ongoing upward trend.
Okay.
But yes, we are monitoring it closely and taking action to address the things that we know are causing it.
Thanks.
Thank you, Fiona. Thank you, Rosemary. We'll move on now then to Helen's report. And Helen, if you can just pull out the highlights, given time pressures. Thank you.
Yeah. No, Russell, thank you very much. That was my intention. Overall, I think we've had very positive performance over the last month in relation to the operational KPIs. So I don't intend to go through those in any detail. I think our recovery has been excellent across our RTT and our elective pathways, and obviously we're not in the position that we would like to be in, and we were probably well this time last year, but I do think our performance has been significant given the challenges that we have. The only one that I wanted to pick out to highlight, and then I will take questions, is our significant improvements in our 62-day cancer performance. And if we compare our performance across the system, actually we were the highest achieving provider within the system for our 62-day cancer performance that month. So I think that's the first time that's happened in a very long time, and so I think that's all credit to the really hard work that the teams are putting into that cancer recovery. So I'll just take any questions, Russell.
Thank you very much, Helen. Rosemary, is that a legacy hand?
Apologies.
Okay. Any questions or perspectives to Helen? Bruce, Chris has said on the group chat, really well done, Helen and team. And Bruce, great achievement on 62 days, Helen. Any other questions to Helen? So.
Helen, I agree, fantastic performance in many areas. I just wondered, you mentioned RTT already, and you mentioned the report that there's some improvements expected next month. So that was just that one, and 2-week breast. I just wondered, what are the next key things that you're looking for this month, and how are they going?
Okay, thank you. So I'll start with the breast service. So we have recruited 2 additional consultant this week or last week, I think that is, and so we will have some additional resource within there, but that won't be immediate. And we have enough funding for a further consultant because we do believe that there are some real challenges with activity and the demand within that service. The team themselves are working really, really hard. So we are working across the system to see whether we can support each of the providers, because we're all struggling a bit with the breast numbers, so we're not on our own with that one. So we are having to repatriate the breast service from the Nuffield as of the middle of December, and that is going to cause me quite a challenge. So we are working through whether we can relocate the whole of the outpatient service for breast in a different location, because their old footprint is not COVID fit for their purposes. So we need to think very differently about that one. So some real improvements on that. But I do think that the 2-week wait performance will struggle for some time. To give you some assurance, that patients are only just missing the 14 days, and the majority of patients then are seen around about 15, 16 days, and it's just those volumes. So there's very few patients go over 21 days. So it's just that immediate response really to the activity that we're seeing. From an RTT performance, we are now working very swiftly through our elective lists. We've contacted all of the patients that are waiting for on the inpatient list to ask them whether they still want to carry on with their surgery, because we know that there are going to be some challenges for us, and whether or not their symptoms have worsened. We're now following that up with a clinical conversation just to check on the health and well-being of all the patients on those lists. We're working through our particular patients that have waited 52 weeks or more, and really making some inroads into those numbers. And they're not the same patients that tip over into those long waiters. And I think what we are starting to see is a bit of that COVID, when we had to, the surge bit, when we had to stop all of activity, and they're just starting to tip over. But I think once we've got to that point, things will start to then improve, and we're making big inroads in our into the recruitment to all of the posts we got as part of the COVID recovery. So there's some real progress on that. So I would only expect to see that get better, unless of course the pressures in the system mean that I have to do something differently around our ITU capacity.
Yeah, no, thank you, Helen. Thank you, Sue. And Helen, there's obviously been some things in the press about the utilisation of the independent sector over the summer. Can you just confirm my understanding that actually our usage of the Nuffield was comprehensive? We basically used all of the capacity they had. They definitely weren't empty when we needed to use them.
No, and we've got excellent relationships with the Nuffield, and we filled them to capacity across a number of served specialties, and we did a lot of pooled work around breast, gynecology, ophthalmology, a number of other. So our use of the independent sector has been excellent across the system, both in both of the independent sector providers. And that's why the change in the contract will have an impact on us. We would have liked to have carried on with the current arrangements we have, but we know that isn't going to be possible. So that will present us as an organisation a challenge moving forward around our elective work.
Thank you, Helen. Sue, you've got your hand still up. If you could take it down, please. So colleagues, happy to move on to Anne's report. So Anne, please brief us on our people, so to speak.
Okay, thank you for that, Chair. I'm very happy to take questions on my report, because I think I've set out in the narrative enough detail to in relation to each of the topics. I think the only thing I'd want to pick up is that our relation to the wellbeing of our staff continues, and we've got, you know, a significant and growing programme that we will keep in place. And just to include in that the recruitment of our international nurses, that because of the quarantine requirements, we have put in a package around supporting them in their first couple of weeks, including providing food and support to them. And I'm happy to take any questions on anything else.
Thank you very much, Anne. Questions or perspectives to Anne? Sue.
Hi, Anne. I note the very comprehensive wellbeing pieces that are being utilised by staff. HSIB did a report into the first part of the pandemic. You and I spoke about it, and it pointed towards some trusts using rosters, changing rosters to help with staff fatigue. And I just wondered whether SWFT has been doing that.
So I think that, you know, I can't give you assurance in absolutely every ward and area, because in some areas it's more possible than others. But as part of our wellbeing support, we're encouraging managers to talk to teams about what it is that they need to support their wellbeing. Because while I fully accept that some people may find a shorter shift helpful, there are other staff who would rather do 3 long days and then have several days off. So it will differ from person to person. So, you know, I think that this is part of it. In addition to that, of course, we've got the individual risk assessment that all staff are having, and that's dynamic risk assessment. So should be repeated should anything change. But I do see it as part of that ongoing conversation that a manager has with their team. Having said that, I have highlighted in this report, and I do every month, that there are areas where the challenge in terms of vacancies is much greater. And clearly, you know, accommodating individual needs on a roster is much harder in a team where there are vacancies that they're covering all of the time. So, I mean, I don't know if Fiona may want to add something, but I think it is on a ward by ward and individual by individual basis.
Fiona, anything you'd like to add?
No, reiterate really for what Anne said. We actually started this before COVID. So we started the conversations with those areas that were struggling to retain their staff, and said, you know, you need just to be as flexible as you need to be, and whether that is short shift or whether that is, you know, night contracts, or whether that is, you know, anything that individual needs to remain in employment and have a good balance between well-being and working life and the home balance, then we need to accommodate it. So I would be comfortable that they know that they have got that message. I wouldn't be able to quantify how many people are doing it.
Okay, great. Thank you, Fiona. Thank you, Anne. I can't see any other hands raised, and thank you very much. Good session this morning that we had for members of the public to be aware on joint workings between the George Eliot and SWFT on people-related issues. But moving on to the numbers, so to speak, Kim.
Thank you.
Pull out the highlights, please.
Thank you, Chair. So the report for the month 7 position shows that we are delivering a £220,000 surplus against a deficit plan for the month of £152,000. So that's a positive position to be. The main driver really, unfortunately, is to do with slippage around recruitment related to some of the restoration work, but that, you know, fortunately that doesn't seem to be hindering us as an organisation. And you will see in the report as well that I've added a few more sort of subjective analysis and run rate tables for information. So hopefully that's useful for the board to have a deeper look at some of the run rate on spend. Key things really, I think, is our cash position remains strong. We've had positive discussions with the CCG to resolve the actual transactions in relation to resolving previous year disputes. I've been assured that cash money will be exchanged hands before Christmas, which is always good to hear. So that's a positive thing. I think the only risk really to identify still is around the elective incentive scheme, which is a system risk, and that still remains a system risk. We haven't been officially told whether or not the elective incentive scheme proposal is going to be effectively invoked for this financial regime. So that remains a risk for the system and therefore a risk to our financial position.
Thank you very much, Kim. Questions or perspectives to Kim? Not a bad day at the office, Kim, when we're entering December. We've still got 46 million in the bank. Rosemary?
Yes, and question possibly for Kim or possibly for other members. Agency spend obviously has been lower for most of the year, but we're actually seeing it starting to creep up a bit and above the standard for a month. Concerns there? Are we on top of it? Are we likely to see that trend continue? What's being done?
Well, I suppose that trend is very similar to patterns that we've had in previous years. We continue to have regular meetings around medical workforce and nursing workforce to understand really the drivers around if it's shifts or rates. And, you know, if need be, we drill down into particular divisions to actually understand, you know, if there's particular problem areas. So we continue to keep, I suppose, tight control over that. I don't know whether or not, you know, anybody else wants to pitch in there.
Kim, given previous years' trends, is it a particular concern?
No, I wouldn't say so, no.
Okay, thank you. And any other questions for Kim? Okay, Rosemary, if you could just take your legacy hand down, that would be great, thank you. And so moving on then to mortality. Charles, anything you'd like to highlight on mortality?
No, the position remains very stable with the mortality indicators under control. And in fact, you can see we're considerably better than our peer group in terms of the in-hospital mortality indicators. I would just mention that we've had one death that's deemed to be avoidable since the last report, but otherwise things are very stable and we've made good progress with the medical examiner model and have recruited our medical examiner's officer.
Okay, that's great, Charles. Any questions to Charles on mortality? Okay, thank you, Charles. Lovely photograph in the back from the Jubilee Bridge, as I have been this morning.
Millennium Bridge.
The Millennium Bridge, I apologise. They didn't build the Jubilee Garden, did they? The nurse staffing report, Fiona.
Yes, just a brief summary again to the board, just bearing in mind time. So thank you, Russell. This is the normal nurse staffing report, which is actually should be entitled differently now because we do include other disciplines in there, as you know. So we've got the AHPs and the midwives in this report on a regular basis, and both the hospital-based teams and out of hospital as well. So for the acute teams, it's a 1% gap this month, and that's made up of some wards that have been overstaffed due to their acuity and a change in bed capacity, bed numbers due to social distancing or closures. And that's explained in the report. Then we've got a vacancy position of 12.3, as you've heard in Anne's report previously, with some hotspots in Frailty and Mary Ward within the acute sector, and teams 7 and 1 in the community. Hotspots on vacancies in AHPs are radiology and theatre staffing, the operating department practitioners, and there's some specific recruitment activity based on all of those teams. The other hotspot mentioned in the report is the community children's nursing service, and we discussed that at the workforce strategy meeting and have agreed to do a skill mix review, looking at some new roles and also a specific recruitment campaign for that as well. Maternity is generally in a good position. We approved Birth Rate Plus as a slight increase in their staffing based on acuity at management board, and they're just in process of recruiting to those posts. They have had an increase in unavailability, particularly maternity leave in months, and self-isolation as well due to COVID, which has caused some pressure. in that department. Out of hospital generally is in a good position, but again in the report, place-based 7 and 1 have been pulled out in terms of sickness and maternity leave. And finally, as you know, the stroke pathway has been approved to, and particularly the early supported discharge team, so they are out for advert and have been successful in some of the senior posts already of the therapy support to that team. So in conclusion, really just assurance that we have good oversight and governance around staffing, and I'm comfortable with the current position in that it's generally positive.
Thank you, Fiona. Any questions, Fiona? That was very comprehensive. Yeah. Okie dokie. Thank you. So the Clinical Governance Committee report for the 11th of November. Bruce?
Yes, thank you, Russell. I just wanted to draw your attention to the testing, which we had some comments from Helen about, that was talked about for the Green Pathway Assurance that we had verbally, and also the first of the Cancer Services Assurance, which we also had from Dr. Hughes Webb at the last Clinical Governance. The IT systems were mentioned within that in order to continue recovery and building of robust services, and I have commented that elsewhere also at Clinical Governance, IT systems play a part in assurance. From our earlier conversations, the Patient Safety Monthly Report, item 2, touches on our conversation into falls and on medication instance and insulin. And the only other comment I'd like to make is that we seem to have lost a line at the bottom of the report. So underneath areas for concern for the board's attention, there should be another item, decisions made and actions taken. The items for IT support are 1.2, 2 and 7. Happy to take any questions.
Thank you very much, Bruce. Questions or perspectives to Bruce? So generally feeling assured, Bruce?
Yes, I think we're well prepared for what might come next as a bigger bulge. I think we're going well at the moment, and the assurance at Clinical Governance has shown a good recovery after the first wave. So as best we can be for the winter and for the unpleasant and unusual situation we find ourselves in with the pandemic. Great infection control.
Okay, super. Thank you very much, Bruce. Colleagues, happy to move on? So we'll move on then to the NED Finance and Performance Committee report for the 3rd of November. Over to you, please, Simon.
Okay, thank you, Russell. Okay, very briefly, 2 things to tease out. We had a very assuring discussion around workforce risks, and I think the executive team have most bases covered in that respect. And also an encouraging debate around, very useful discussion around productivity, efficiency, performance KPIs. And there has been a subsequent meeting, and Kim and her team are working on half a dozen or so KPIs that will give us a regular heartbeat on productivity throughout the organisation. And I think the only area really that the board needs to be cited on, and clearly is cited on, is the pressure and stress on the workforce as we move into winter with COVID, and to continue to support it wherever it can. And that has been said clearly by many execs as well. So happy to take questions.
Thank you very much, Simon. Questions or perspectives to Simon on the F&P? Thank you, Simon. Glad that's bedding in well. The Council of Governors report for the 12th of November I'll take as read. Any questions or perspectives on that? Just like to put on record again my thanks to all the governors and their hard work. It's difficult for everyone, this COVID period and a period of lockdown, and the governors have continued to work very diligently during what's been difficult for everyone, so thank you for that. The monthly update on trust performance against national guidelines on learning from deafs. Apologies, I had passed over in my enthusiasm from the Foundation Group Strategy Subcommittee. I do apologise, Chris. Do you want to pull out the key points, Chris?
Yes, thanks. I did wonder whether you were going to doing this report. Yeah, just to say that I'm taking it as read, but just to pull out that there was a really excellent report from Ali Bolton in terms of quality improvement. And I think what she demonstrated is the real benefits of sharing best practice. So I think that's a really good model and one to be congratulated. The principles, as we said, we will be reporting on those 6 monthly, and rather than create yet more principles, it was agreed to use the trust strategy, and importantly that we take that to place. The areas of shared services, the reports are in the confidential section, which I will comment on later, but just to say that it was not just about pace, but it was also about levels of detail as well. Happy to take any questions.
Thank you, Chris. Any questions or perspectives to Chris? We are covering, as Chris has said, the issues of procurement, shared services and financial services in the confidential section. Okay, great. Thank you very much. I mean, I think just for members of the public, we are at the moment going through an exercise of assessment for a new electronic patient record system. And one of the really encouraging things is we've had input from across the foundation group on what the ideal system should look like. And we had a presentation on that this morning led by Helen, but with colleagues like Ben Atwood and Andy Laverick and Adam all taking input from the foundation group. So the foundation group is having an impact across many different ways in which the trust works. Charles, in my excitement, I was leading us too early into your section, but the 6 monthly update, please, on learning from deaths.
Yes, and I think that the paper speaks for itself. As you can see that he remains well controlled within the indicators. The medical examiners system is now well established, fully recruited to, and has been much benefited by its lead, the online modus operandi. We've now actually recruited to the medical examiner's officer, and the IT system that we were getting from Y Valley, has now been put in place, and it's just about ready to go. So, generally, good progress.
Thank you very much, Charles. Any questions to Charles on the learning from deaths report? Okie dokie, thank you, Charles. So the COVID-19 and winter plan updates. Helen?
Thank you, Chairman. I will take the paper as read, and you've heard me talk on a number of occasions about our planning for the next surge, the mitigations that we put in, but also for our winter plan. So to give the board some assurance, I just want to turn your attention to the chart that's contained within the report, which looks at our actual and versus our predicted bed requirements. And I think that chart, if we look at the green wiggly line, which is our actual bed usage compared to what we had predicted for the winter, gives the board some assurance that we are managing the impact of COVID, that our bed requirement scoping was robust, and that the plans we have in place are helping us to deliver a safe organisation and also deliver our operational targets.
Great, thank you very much. Quite a remarkable sort of outlook given the challenges we're facing. Questions or perspectives to Helen? So,
I just wanted to echo that point that you made, and Russell, in terms of the performance and the high level of assurance that this report gives, especially considering many of the challenges that we've already touched on in board, in terms of testing, for example. So I just wanted to say such a heartfelt thanks to the team for all they're doing and for the planning. Thank you, Sue.
Thank you, Sue.
So colleagues, happy to move on? So your hand went back up. I assume that's a legacy. Delighted to welcome Sue Pike for the Freedom to Speak Up Guardian's quarterly report. So,
Hello, thank you, Chair. So I'll take the paper as read, but a couple of highlights for some new activity in this quarter's report. So you'll notice figure 1, we've put a length of time around casework in the report. I did anecdotally feel that a lot of reports take a long time to close down and a lot of cases take quite a while, but actually the evidence is showing that the majority of ours are closed within 4 weeks. In fact, quite a significant amount are closed within 72 hours, which is fabulous. You'll see on the report that there are a few cases that have gone on for over 6 months and a couple even over 12 months. Those cases tend to be related to other activity. It may be that the individual is unwell and is actually out of the workplace. It might be that there's a HR process or another action going on around the individual or around the case. To close down a case, I usually check in with the individual that spoke to me in the first place to make sure that they are happy with any outcomes that they've had. And usually I'd wait for any grievance procedures or disciplinary actions to be gone through and completed before I'd close it down. So those are the ones that you see taking a longer time. Also new for this quarter is one of the themes. I've actually added mental health as a category of its own. That's to pick up on the fact that a lot of staff report having mental health issues as a result of what's happening to them in the workplace. So this usually it's around stress or extra anxiety. I don't include that as a category if they have pre-existing mental health. It's only if they feel that they've come into contact with excess stress or that they've felt poorly as a result of the concern they're speaking about. So that's new. You'll also notice that the actual way of recorded cases, so in terms of worker, manager, senior person and the categories around AHPs, nursing, midwifery, they've changed. And the reason for that is because the NGO has changed how they want us to report to them. So I've just reflected it in our report and that's how it will look going forwards. The other thing that's fairly new is I've changed how I get feedback after speak up cases. It used to be a paper-based form, which was a bit arduous, so I've changed it to be a Google form. Everybody that speaks to me that has a case has a form to fill in. They don't have to do it. I don't hit them and tell them they've got to, but this quarter we had 12 returns, and of those 12, 10 of them actually said they would speak up again and did find the Freedom to Speak Up support really useful. A couple of comments from that feedback. I felt listened to and the support was useful and much needed. Another one said it's boosted my confidence to speak up and I'll definitely do it again if I need to. So on the whole, most people are happy with the experience. Of course, you get one or two that aren't so happy. One of those members of staff was a little aggrieved because they felt they were the ones that had to move from their position of work rather than the person that they were complaining about. But sometimes that's the decision that's made through a HR process. As usual, the common themes in the report are behavioural issues, leadership style. There was a little influx in nurses reporting this quarter. Usually our nursing workforce tend to use Datex, but it might be because we've had more engagement with nurses through our staff networks, so being in contact with them. And we've also used other methods for getting in touch with our staff this quarter, including Facebook, and I've even had Twitter DMs and all sorts of people raising concerns that way. So it's been an interesting quarter. And it would be remiss of me, even though it's in October. October was Speak Up month and it was an amazing month this time. We did loads on social media, did lots with the National Guardian and locally. And of course, we ran our first virtual conference, which was across the foundation group, but wider than that, we had Guardians dialing in from Poole and Dorset and all over the place. So it was a really good, positive event. And thank you to all of you that were involved with putting that on. So I'll take questions. Thank you.
Sue, thank you. You do a great job for us, and we're very lucky to have you. Questions or perspectives to Sue? I think that's a recognition of the great job you're doing for us, Sue. Thank you. Carry on.
Much.
You have a good afternoon. We then got the progress report on annual trust and foundation group objectives. I'll just see if Glenn joins us later and maybe come back to that. But we'll move on to summary of ratified policies. Anne?
Yeah, thank you, Chair. This month we've got the email policy, and a summary of what's included in that policy is provided. So it's quite self-explanatory and there for information.
Okay, thank you. Any questions on the summary of ratified policies? Okie dokie, thank you very much. And then the appointment of consultants, Anne Pope?
I've nothing to add to that, Russell, thank you.
Okay, any questions on the appointment of consultants? Okay, so we then moved on to the board committee minutes. The Clinical Governance Committee of the 14th of October. Bruce?
Nothing to add, Chair. Any questions?
Any questions from colleagues? And then Simon for the NED F&P of the 2nd of October.
Nothing to add, Chair.
Any questions to Simon? So then just pop up the agenda to the annual trust and foundation group objectives, which can be found, I think, on page 121 of the board pack. Just bear with me. I'm still finding it, but colleagues can see it's all green and amber. The amber sections relate to the multi-storey car park and the work on end-of-life care strategy and the review of non-acute beds and exploring new models of care, which has been affected a bit by COVID, and the moving more care into out-of-hospital community areas. Anne Coyle, is there anything you want to add to the report?
No, I think you summarised it, and just to say, as been mentioned already in this meeting, it's a remarkably positive report given the context in which the organisation is operating.
Okay, any questions therefore on the report? Okie dokie, so I think then we're on to any other business. Any other business from, I apologise. Any other business from colleagues? Please put your hand up. Okay, I'm aware of two members of, or two colleagues, two governor colleagues who have got questions. One is Roger, one is David G. I don't think David G is online. Sarah Claire, do you want to do David first, please?
Thank you. So David notes from the recruitment report that a number of nurses have been recruited from India. Whilst they all speak English, does the trust ensure that their speech is not so heavily accented that patients with less than good hearing cannot easily understand them? I think Fiona and Anne are going to answer this question.
Thank you very much, Sarah.
Shall I start, Russell? So, I mean, obviously, these nurses recruited from overseas are interviewed in the same way that any other nurse would be. So there is an opportunity for an interview panel to have a conversation with them. But more than that, all international recruits are required to take an English language test. So that's a mandated requirement nationally.
And Fiona?
And that test is verbal and written, isn't it? And
that's right. That's right.
Just to reiterate, and it's hard. You know,
Yeah.
there's a significant non-pass rate. It's not an easy one. And then once they have got through those steps, we have a significant induction period, retraining period, and then their NMC license. So I'd echo what Anne said. I think it's a very robust system that assures us that they are fit to practice and communicate.
Okay, thank you very much. And then Roger, I think you had a question.
Thank you. Yes. In Anne Coyle's commentary at item 7.2, there's reference to SWFT taking over as lead for the STP integral care record and an extra capital cost for the capital programme. How does this mesh in with the work being done on the patient portal project?
Thank you, Roger. Anne?
Yes, thank you, Roger. I've discussed this with Adam Carson, our Interim Chief Technology Officer, and the Integrated Care Record and the Patient Portal, they are, while they're separate things, they do complement one another and they will draw on the same data, but they're not overlapping. So they are two distinct products that that will coexist.
Okay, thank you, Anne.
Thank you.
And do we have any other questions from members of the public? If you could raise your hands, that would be great. Okay, well, thank you all very much for joining us. This is our last board before Christmas. Normally we have mince pies to share with members of the public after this board, but in advance of Christmas, unfortunately, we can't do that. I know for some, it's been a very hard few months during COVID in the summer, and our thoughts are with you. But in the meantime, can I be one of the first to wish you all a Merry Christmas, and I look forward to seeing you all in the new year. Colleagues on the board, if we can dial out and dial into the confidential board, we'll have a 10-minute comfort break. Thank you very much, and everyone take care. Stay safe.